Thank you for joining us today. We're live at Hospital for Special Surgery's main campus in Manhattan, bringing you important information, medical information, I should say, and important patient stories that could help you in your decision-making process for orthopedic and rheumatologic care. I'm joined today by...
I'm Dr. Alejandro Gonzalez Della Valle, and I'm an orthopedic surgeon specializing in surgery of the hip and the knee at the main campus of Hospital for Special Surgery.
And I'm Daniel. I was Dr. Della Valle's patient, and pleased to be here today to talk about my experience.
Thank you both for joining me. We'll start with you, Dr. Della Valle. Tell us, what are some of the things that patients need to know when they're considering knee surgery?
I would say that the most important factor is sometimes a fear factor, because patients have the impression that they are going to come to see a surgeon and that the surgeon will want to operate on that patient. And that is certainly not the case in our hospital. I think that our most important job is to understand what the patient feels and what are his or her complaints. In terms of joint pain, they can complain of pain, they can complain of stiffness, and we need to understand how these symptoms actually affect the patient's quality of life. And that's our first job. And that's how everything starts.
That's how it starts. So, Dan, I'm going to shift to you a little bit.
Okay.
Given some of the things that Dr. Della Valle was saying, are there some of those things resonate with you? Can you talk a little bit about how you felt?
Sure, no, they do. Again, I had, over the years, developed knee pain. I had a meniscus tear about, say, 25 years ago because of kendo, which is the Japanese fencing that I was doing actually in Tokyo at the time. I had one practice. I bounced off a teacher who was built like a truck, and I landed on the floor, sort of knee first, wood floor. Tore the meniscus, had surgery, that was fine. And then in recent years, I was having episodes of pain and PT and trying to take care of it, but it wasn't really working. And so I was, cortisone and sort of Band-Aid measures to try to help, which weren't successful. And then I found out about HSS. I had a good friend who had worked with Dr. Della Valle and had performed surgery on him, spoke very highly. And I had recommendations for other hospitals and even other physicians here at HSS, but I heard such good things I wanted to meet with Dr. Della Valle and understand the process and what his recommendations were, and very fortunate that I did. Yeah.
Is this typically how your patients present? Everyone's looking into being active and staying active. And is this a story that you do hear most often in your practice?
Yes, when you have a mature practice, then a proportion of your patients see you because they are referred by other patients. Right? And the idea is that once you know what the complaints of the patients are, then you try to come up with a treatment for it. And the idea behind an orthopedic treatment is that we want to offer the patient the most minimally invasive intervention that will give them the longest possible result for what they actually want or they actually need. Sometimes it can be a simple injection, sometimes it can be a prescription for physical therapy. It doesn't need to be surgery.
Are they surprised when they hear that? Are patients surprised when you're saying, okay, wait, we're going to try other options first and then we'll evaluate?
Yes, for a number of patients who don't have severe arthritis, who have mild or moderate wear of the cushioning or the cartilage of the joint, we try non-surgical options. We offer them bracing, injections, physical therapy, etc. In the case of Daniel already tried all those things. Also, he mentioned that he also tried arthroscopic surgery for a meniscal tear. And in his particular case, there was no more cushioning in a particular area of the knee in which we can focus later on.
And Dan, when did you determine that, you know what, I need to go and really seek out another opinion for my knee?
Well, interestingly, I was working with another physician who recommended a regular full knee replacement, and I had done some research, was aware of a partial replacement, what that meant. I wasn't sure if I was eligible or not, so I sought a second opinion, and that's what brought me here. And what I really liked was Dr. Della Valle didn't prescribe or tell me what to do. He basically said, this is your condition, these are the x-rays, this is what you can expect to happen if you do nothing, and basically guided me to the conclusion that a partial replacement, again, of the 3 compartments of the knee, the inner one was damaged, the other 2 were okay. And so based on that knowledge and his ability to explain it clearly and sort of forecast my hoped for ability to recover. I remember in the first meeting I brought an iPhone with a YouTube and I showed a kendo video and I said, this is what I do and this is what I want to get back to. And you fully understood and kind of took it from there, which was great.
And in understanding your goals, and working out that and being an active part of that treatment process, how did that make you feel even as a patient?
Well, it made me feel really invested in the process, that I was part of the decision-making process. I wasn't just being told what to do by somebody who had many years of experience, of course. And so that participation, also that being on the same wavelength, sort of cultural fit, was all very important to me. And from the very first meeting, I felt a sense of trust and understanding about my condition and what it would take. And there was no guarantee, but based on his experience and what he explained to me, this seemed to be the best course of action, and that it absolutely happened, and, which made me feel great.
And Dr. Della Valle, given that Dan had such a great athletic ability and pretty much is very strong,
No,
okay, not at all,
No.
but how did the prehab process for him, how did that work in terms of preparing him for surgery?
Yes, some patients benefit from doing preoperative physical therapy. Daniel is a kendo instructor, so he was in perfect shape. That was unnecessary. In his particular case, the decision was what to do. And another fear factor for patients is that, and maybe this will relieve the anxiety of some potential patients that are thinking about coming to the hospital, is the fact that most orthopedic conditions do not require an urgent care. For example, if I'm having a heart attack, you need an emergency procedure. If you're having an appendicitis, you need an emergency procedure. If you have a bad knee or a bad hip or a bad shoulder or a bad elbow, it's very rare that you will need urgent care. That means that most of our patients receive education from us so that they can make an educated decision in relation to their care. In the case of Daniel, the option was to do nothing or to do a knee replacement, which can be either total, as he very well explained, or partial. And generally, partial knee replacements in a selected group of patients allow them to go back to a more active lifestyle. The knee feels a little bit more natural, the recovery is a little bit faster, there is less blood loss. Okay, so those are the advantages of doing a partial versus a total knee replacement.
And Dan, take us back, I
Sure.
should say, to your day of surgery and what that experience was like for you here at the hospital.
Okay, it was. I remember. I think I got up at 5 in the morning. My wife and I came in to the hospital. Dr. Della Valle was there very early and came by to say hello. And it was interesting. He basically has his checklist of a process in terms of. We were talking. He said, "Well, why are we here, Daniel?" I explained which side. Remember, you sort of initialed and put a bullseye right there to make sure that there was no question about it. There's a great book called the The Checklist.
Manifesto.
The Checklist Manifesto that talks about that. And I really had the feeling every 5 minutes people were asking me on my birthday, make sure I was who I was. 8 o'clock surgery, I was first up, which I hear is a good thing. But afterwards, when I was post-surgery, he went into the waiting room, gave my wife an update. He came upstairs 2 times in between procedures to give me updates and see how I was doing, which was great. And even before the surgery, I think a week or 2 before, I had tests, x-rays, blood tests, that sort of thing, just to make sure there weren't any reasons or complications why I couldn't undergo surgery, and green light, so that worked out. So just the attention to detail, the focus on getting it right and process really impressed me about HSS. Yeah.
And how does that make you feel, even as a surgeon working here, and knowing that those are the processes that are in place that cuts back on that fear going into surgery?
And not only that, Tracy, it's great for the patient, but I think it's also great for the surgeon, because I think most of us feel blessed to be working in a hospital in which the security guard, the nurse, the physical therapy, the surgeon, everybody works with a lot of cohesiveness and putting patient safety and having an excellent outcome first. And it perspires to patients, and it perspires to us and to all the employees of the hospital who feel that there is no better place to work. So not only the patients are lucky, I think we are all very lucky to be working here.
And can we talk a little bit about his case itself? Was it like in line with most cases, or was there any difficulties that you found?
No, one of our jobs, once the patient decides to proceed with an operation, is to understand what are the potential problems, the potential difficulties, the potential complications. And the idea is to offer a treatment to a patient that has a low risk of having problems and the high chance of being highly rewarded in terms of gaining function and going back to an active life. And that was Dan's case. He was a very low risk patient with arthritis in one of the three compartments of the knee. So he was actually a perfect candidate for the procedure. Having said that, we have to keep in mind that the results of surgery cannot be guaranteed, right? There is a small risk of complications with any surgical intervention, including arthroplasty or prosthetic replacement of the hip and the knee. The early complications are lower for partial than for total knee replacements. That's why patients who receive a partial knee replacement in the hospital have a shorter hospital stay. It's a smaller operation, they bleed less, they hurt less, and oftentimes they go home on the same day of surgery.
Which was my case, yes.
Could you explain a little bit the difference between a total knee replacement and a partial, just for someone who in the audience who may not understand the difference?
Well, Daniel explained it very, very well.
Yeah, I have a future career in medicine, right?
Daniel, you explained it perfectly, I have to say. Well, let's begin by the fact that the term total knee replacement can be a little bit misleading, because some patients may have the impression that we are going to cut here, cut here,
that was my first
and give a
impression,
new
yeah.
knee. No, that's not what a total knee replacement is. As Daniel was very, very well explaining, a knee has three parts. You have the inner part of the knee, the outer part of the knee, and the front part of the knee. And cushioning, this cartilage that is worn by arthritis, is present in all three compartments of the knee. Oftentimes, and in the majority of patients, arthritis is affecting more than one compartment of the knee. And that happens to the majority of our patients who see us with knee arthritis. Under those conditions, if at least two of the compartments are very badly affected, the right thing to do is to replace all three compartments of the knee with a thin implant. And that thin resurfacing implant is called a total knee replacement. So the word total means that all three parts are replaced. Having said that, even a total knee replacement preserves the majority of the ligaments, all the tendons, all the muscles, and the majority of the bone around the knee, as opposed to a partial knee replacement which just resurfaces the affected compartment of the knee. In Daniel's case, it was the inner compartment of the knee, what we call the medial compartment. In some other patients, it can be the lateral or outer compartment, and in some other patients, just the front part of the knee. And when we just replace that compartment, we call that a partial knee replacement.
Do you find that, most people who come in with partial or may be on that list of needing a partial knee replacement fall in line to that group that are active adults but have probably skated into that area of osteoarthritis? And is that something that's really prevalent today?
Yes, generally partial knee replacements are used in a younger population than total knee replacements.
we have a question?
So we have a question from Andrea. Andrea is a patient who is from Iowa, and she's wondering if traveling such far distances with disabling knee problems, if that is something that she should come to HSS for. She's had answers that nobody or no one can seem to offer answers, or are too afraid to try to offer an exclamation. So any overall thoughts on traveling here with a knee problem when maybe people have been discouraged from prior visits to other physicians?
Well, Tracy and Daniel and everybody knows very well that the hospital has a very, very well-deserved international reputation, and as such, we see patients that come from all over the country and also from all over the world. And we have people in the hospital whose job is to try to make the life of patients who come from out of the tri-state area easier, providing them with information and counseling about staying in the city before and after surgery, making their lives easier while they are in essentially a city that is not their own.
You have anything you want to add to that? I know.
No, I think it's worth traveling. I'm lucky because I live locally,
right.
So that was quite easy. Just one footnote to what the doctor said about pre-surgery. I did physical therapy for a couple of months even before the procedure because I wanted to have strength in the leg muscles and that sort of thing, as well as afterwards. I think physical therapy after surgery is extremely important to sort of get back on your feet, so to speak, and become more active more quickly. And so, I mean, it's a lot of work. 2-3 times a week physical therapy, but it's working great, and I think that's an important piece of the recovery process. Yeah.
And we can talk a little bit more about that. Given that you're an athlete, how difficult is it for you to, when you start to feel better, to also recognize the fact that you are X months out from surgery and that you do need to follow the pace a little bit and listen to your body?
Well, I probably shouldn't say this in front of my doctor, but there was a time, I want to say, this was sort of mid-July, so a couple of months into it, and I was feeling great, so I had a kendo practice. I think I went hiking later that day, and then I mowed the lawn on Sunday. I was just like, so Monday comes, and I'm like, what have I done to my knee? I was feeling, like 2 steps back. But
right.
So to your point, you got to sort of take it as it goes, take it easy. You will get there, and your knee will improve, your mobility will get better. I mean, everybody is different, but I was fortunate in that respect. But you just have to take it, be methodical about it, have belief in and trust in your caregivers, whether it's your surgeon or the physical therapist or whoever you're working with, as well as family too. I plug for my family because great support throughout the process. I mean, it's really helpful to have people who are aligned with your interests and want to see you recover quickly. And it's not just Dr. Della Valle, but the people around me were very supportive as well. So it's sort of a group process to get you back to where you want to be.
Tracy, may I add something
Sure.
in relation to what Dan just said? That the general belief is that if you're going to have some sort of hip or knee replacement, your surgeon is going to just work on the bones, which is not necessarily true. We have to get to the joint by producing some sort of surgical injury to the soft tissues around the joint. That's how we get to the joint. It's part of the surgical skills to do so with minimal damage to the soft tissues. And whatever damage we produce while getting into the joint, then we carefully repair with stitches, so we bring all the tissues that we moved away back together. As Daniel was pointing out, it's very important that the patients understand that those soft tissues need to heal, and that takes time. So a lot of the early recovery after a knee replacement focuses more on flexibility than on gaining strength, right?
Right. So is that something that you learned along the course of the way, or you kind of understood?
It sort of happens.
Right.
Again, the people guiding me through the process understand that. There's certain, again, kendo practice. There's certain exercises or positions that I'm not quite there yet. I'm trying to take it, gradually getting back to my original condition. But you just have to, again, be methodical about it. Be careful, not push it, and enjoy the gains as they come. Yeah.
And let's talk a little about the pain management aspect of any surgery, but particularly knee surgery. A lot of people have said that, oh my gosh, it's a terrible pain to try and maneuver, right? What is being done today to help manage that pain a little bit throughout this process?
Tracy, that's a very important point. Knee replacement surgery, particularly total knee replacement surgery, has a reputation for being an operation with a very painful recovery. And the reason is very simple. It's a very superficial joint. And the incision is made in the front part of the knee. So with every attempt at straightening and with every attempt at bending the knee, the patient is stretching and contracting all the tissues that we move away to do the operation. So it's certainly a relatively painful procedure. On the other hand, in the hospital and in other hospitals around the world, the treatment of the perioperative pain after a knee replacement has substantially improved. And we do a lot of different things. Our anesthesiologists will use blocks, injections in the front part of the thigh, in the back part of the knee, so that early after surgery the patients feel better. We will also routinely now inject the tissues around the knee replacement with local anesthetics, so that the first few hours are actually quite easy to handle. The challenge is that the patients need to understand that those anesthetics, those injections, will only last 6-12 hours, and that after that the patient will have to start taking pain medication. The idea is to take the pain medication early, let's say when the pain is 2 or 3, instead of waiting until the pain is too late, the pain is 7 or 8 or 9,
Right.
because then the patient is set back, he or she cannot do physical therapy on that day, etc. So education and early intervention is very important, and really have been a game changer in relation to total knee and partial knee replacements.
And of course, this is information that's shared with the patient. I'm sure it's several times throughout the process, but I guess absorbing that information sometimes in real time only comes toward the end, when they're actually in that process of.
Not only that, we try to adapt the pain medication to, not all the patients react the same way to the same pain medication.
Right.
So our job in a way is to understand how the patient feels. What's the past medical history of that patient that would make us change the protocols that we use. And there is a lot of dialogue between our pain management specialists, our nurses, and the patients, so that the patients can give us feedback that would allow us to trim and adapt the type of pain medication while they're in the hospital, so they go home with a medication that actually works and produces minimal side effects.
And Dan, I'm going to turn back to you a little bit so we can talk a little bit more through of your recovery process.
Okay.
So you're a few months into physical therapy right now.
Let's see, 4 months.
4 months. And how is that going for you?
It's going very well. Again, I have identified a great place, sort of gradually moving my my routines to be more challenging in terms of stretching and weight training and that sort of thing. So and it's near where I work, which is very fortunate as well. So I think that's an important piece to the success of the surgery is, again, the follow through, the physical therapy, getting enough sleep. Diet is very important. We really, sort of organic foods and healthy foods, I think, are important to make you, have enough energy to do physical therapy, to go back to kendo practice, to go back to work, and function, as well, if not better, as before the procedure. So that's my goal.
And do you find yourself constantly setting small goals for yourself to hit them, and then also feel better about your recovery process?
Yeah, I do. For example, before a kendo practice, I'll focus on something that I want to teach my students, or something that I want to personally do, recognizing that maybe I can't lunge or move in exactly the same way as I did before. I will someday, soon. I'm making good progress, but so I'll have sort of benchmarks or goals, not just for that, but for other activities during the day, so that I can, at the end of the day, look back and say, hey, I did this, or here's where I need to work a bit more to realize, full recovery. So.
And for other patients out there who may be in similar situations and right now kind of trying to make that decision about whether they should even see an orthopedic surgeon or be evaluated for their condition, what would you say to them in terms of trying to take care of your mobility issues?
Yeah, I have given some thought to that. I think it's very important to, as we get older, which we all are, to be focused on not just our health, but also being active. I think activity is very important, and I think if you do have a knee condition like I did and you just throw up your hands and give up, that's obviously not an option. You want to focus on activities and lifestyle choices that allow you to remain strong, and if you do need surgery, to be in a position to benefit as much as possible from surgery. HSS did that for me, which I'm very grateful for. But I think those are some of the things. Again, remaining active, focusing on again healthy lifestyle, and I recommend this procedure where it makes sense and where it's sort of medically beneficial to those of you out there who may have a similar condition.
And when you face patients who are, like you said, a little nervous or concerned about the actual surgery itself, what do you do to walk them through and helping them make that decision?
I think that first the key is to understand that if you have an orthopedic condition and you need to see an orthopedic surgeon, there is an enormous chance that the nature of your problem is not an emergency, it's not medical emergency. And that means that your orthopedist or your orthopedic surgeon will try to educate you in terms of what options you have for non-surgical and for surgical treatment. Now, I think that the most important factor in diminishing anxiety in the patient who needs an operation is for us to be as surgeons straightforward and to try to understand the patient's complaints, to try to understand the expectations, and to understand, based on our knowledge, how, if we are going to be able to fulfill those expectations with any type of surgical or non-surgical treatment. We need to speak both the same language. If Daniel wants something that I cannot give, it doesn't work that way.
You were very good at managing expectations, I thought, in terms of leading me to the solution, understanding it fully, but also understanding that there are, it really depends on how it goes, and fortunately it went well.
And also, understand that in any orthopedic procedure, the results cannot be guaranteed. But generally in our hospital, we offer surgery to patients who have a very high chance of doing very well, so that the risks are minimized.
Well, I'd like to thank you both for joining us today and sharing this important information. Thank you all for tuning in. If you have questions, you can continue to leave those for us in the comment box, and we will get back to them as soon as possible. And also, if you want to find more out about Dr. Della Valle or Daniel's story, please check out hss.edu/back in the game. Thank you.